Assessment of the presence and extension of coronary artery disease is usually part of the workup in patients with the chronic kidney disease awaiting for a kidney transplant. Is it worth this assessment? Myocardial revascularization procedures do offer a benefit in terms of risk reduction in that particular population. My name is Luis Godak, and I'm a professor of cardiology at the Heart Institute in São Paulo, Brazil. In Mayo Clinical Proceedings in March, our paper entitled Coronary Artery Disease Assessment and Cardiovascular Events in Middle-Aged Patients on Hemodialysis will appear. In this paper, we explored whether in younger patients on dialysis with longer life expectancy, assessment of coronary artery disease could identify individuals at a higher risk of events and whether revascularization might improve outcomes in selected patients. And this is contrary to what had been observed in elderly patients. Our own group has previously published that in elderly patients, this kind of assessment and even myocardial revascularization procedures, they do not offer a benefit in terms of reduction in the incidence of cardiovascular events and all-cause mortality. So in this study, from a cohort of more than 2,000 patients, we selected 1,374 patients, asymptomatic patients, middle-aged patients with age between 18 and 64 years. And then those patients underwent a clinical risk stratification, cardiac scintigraphy by a single photon emission computed tomography SPECT, and all of them, 866 patients, also underwent coronary angiography. And the primary endpoint was a composite incidence of cardiovascular events, non-fatal and fatal, and the secondary endpoint was all-cause mortality. And as expected from a high-risk population, there was a high incidence of the primary endpoint. 24% of the patients experienced on a median follow-up of 26 months a cardiovascular event. And those patients who were clinically stratified as being at a higher risk, they had a threefold increase risk for the primary endpoint. And the prevalence of abnormal findings on perfusion scans was 29%, and significant obstructive coronary artery disease. We found more than half of those patients, 52% of those patients, they had a significant coronary artery disease. And in terms of risk stratification, when you look at any abnormal findings on the myocardial perfusion scans, and even with the significant coronary artery disease, there was a significant increase by 74% and 22% increased risk of cardiovascular events, respectively. And in those patients who were deemed adequate for a percutaneous coronary intervention or a bypass surgery, there was a significant 18% reduction in the risk of all-cause mortality relative to patients on medical treatment. So we conclude, based on this large cohort of middle-aged asymptomatic patients undergoing dialysis, waiting for a renal transplant, underwent this very comprehensive cardiovascular assessment, that we could identify a high risk, a subset of patients, a higher risk subset of patients for cardiovascular events, and that coronary intervention, myocardial revascularization procedures, indeed was associated with reducing the risk of death in select patients. When you think about the cardiovascular assessment that has been proposed in different guidelines, they usually do not consider age as a confounding factor in terms of what would be the benefit for cardiovascular assessment and if the patient is deemed adequate for a myocardial revascularization procedure. Because we had data showing the opposite, that this cardiovascular assessment is futile when you were considering the benefit in terms of cardiovascular reduction, in terms of events. So what we have shown in our study is that when you took age as a confounding factor, maybe those younger patients should be more carefully assessed because the benefit could be there for those patients at a younger age. And of course, if you have an elderly patient, maybe because of a lower life expectancy, the benefit of such assessment and of a myocardial revascularization may be not so clear for the elderly. When clinicians are called upon to assess the patient, they should consider age in their model for what would be the benefit of assessment and a myocardial revascularization procedure. The same goes when we are reading any study in terms of the benefits of assessment of assessing the patient in terms of the presence and extension of coronary artery disease, and whether the benefit for myocardial revascularization is there or not. So again, we have to assess the patient very carefully in terms of the life expectancy of the patient. The younger the patient, more likelihood, more probable the benefit will be there. And in the opposite, on the other hand, the elderly, the patient, maybe such assessment is such a futile strategy. It's no use for the patient. One area that I think we're still missing, and we own that for those patients, is we have to have more randomized clinical trials. We have a lot of observational studies, larger registries like the one I just presented in this video, but we still lacking a lot of randomized clinical trials, more robust evidence to guide our choices when we are choosing the best therapeutic strategy, not only for a better treatment, but even before, how is the best therapy, the best choice for the proper diagnosis for those patients in terms of the cardiovascular disease, the presence of cardiovascular disease, and then what is the best strategy for treatment, medical treatment versus interventional treatment. So this is an area I really believe we should be more focused on, which is more randomized clinical trials for patients with the chronic kidney disease in terms of cardiovascular outcomes. If you want to have more details about this study, please read the paper we published, will appear in March in Mayo Clinic Proceedings for further details. Please, thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.